62-year-old female, sudden syncope while walking, no chest pain, vitals stable during transport.
Now, what should we do next?
Hi everyone. Here we share short, high-yield videos that blend essential emergency medicine knowledge with real-life ER experiences. If you're looking for practical, to-the-point content you can apply on your next shift, you're in the right place. Don't forget to subscribe and leave a comment if the videos help you out. See you in the next one. Think of this slide as a pocket-sized mental flashcard. Take a screenshot if you find it helpful. We will include at least one like this in every video to reinforce key points. Syncope is a transient loss of consciousness due to transient global cerebral hypoperfusion characterized by rapid onset, short duration, and spontaneous, complete recovery. The primary goal in patients presenting with syncope should be to avoid missing life-threatening diagnoses. These include myocardial infarction, subarachnoid hemorrhage, aortic dissection, hypertrophic cardiomyopathy, ruptured ectopic pregnancy, gastrointestinal bleeding, and aortic stenosis. Patients with pre-syncope should be evaluated similarly to those with true syncope. In elderly patients with recurrent episodes, carotid sinus hypersensitivity should be considered. For female patients of reproductive age, a pregnancy blood test must be remembered to rule out pregnancy-related causes. To identify high-risk cardiac causes, which carry the greatest mortality, clinicians must deepen the clinical history. For discharge decisions, validated clinical decision rules should be applied. In this context, postictal state assessment helps differentiate seizure from syncope. Among available risk stratification tools, the Canadian Syncope Risk Score is highlighted in Tintinalli's Emergency Medicine textbook. The slide presents red flags to be vigilant for during history taking, particularly to assess the probability of a cardiac etiology. Certain lab and imaging findings should raise suspicion. ECG findings must be interpreted carefully. Orthostatic changes combined with melena suggest potential GI bleeding. Anemia and hypotension are significant red flags that may warrant hospital admission and advanced diagnostics. Ischemia blocks slow AF, persistent sinus bradycardia, sustained VT or non-sustained VT dysfunction of a pacemaker or ICD Brugada pattern, long or short, QT, delta wave, epsilon, wave. The ECG abnormalities presented in this slide are considered high risk and must be carefully evaluated to avoid missing potentially life-threatening conditions. Syncope on supine position, syncope after palpitations, structural heart disease, e.g. aortic stenosis, cardiomyopathy, presence of a pacemaker, syncope occurring during exertion, absence of prodromal symptoms, family history of sudden cardiac death before the age of 50. The items listed here indicate a higher risk of cardiac syncope and should raise clinical suspicion. We frequently use this website in the clinical setting, especially for decision support scores. You can access all the syncope-related decision tools mentioned in the introductory slide through this platform. Among the available clinical decision rules, the Canadian Syncope Risk Score is particularly emphasized in Tintinalli's Emergency Medicine. The individual components of the score are provided here for your review and practical use. This scoring system is applicable to patients aged 16 years and older who have experienced syncope within the past 24 hours. A score of 1 or higher may suggest the need for hospital admission for further evaluation of potential cardiac syncope. Here are some clinical tips to help guide and protect your practice. Continuous cardiac rhythm monitoring is crucial. Absence of a postictal state can aid in differential diagnosis. Reassessing the patient through repeated questions during observation may reveal critical aspects of their medical history. I would be glad to hear about your own experiences. Feel free to share them in the comments below. Thank you for watching. I hope this content has been helpful in your daily clinical practice. If you found value in this video, please consider subscribing and sharing it with colleagues who might benefit. Remember, the information provided here is intended for educational purposes only and does not substitute for clinical judgment or institutional protocols.